All right, good morning, everyone. It is 9 a.m. on Friday, August 16th, 2024. Gonna go ahead and hand it to Chair Khan to go ahead and get the meeting started today.
Thank you, Joseph. We'll call the meeting of the Patient Protection Commission to order. And Dr. Khan chairing the commission's meeting with the Nevada Department of Health and Human Services. So, Ed, you may go on, take the roll call, please.
Thank you, Chair Khan. Joseph Filippi, Executive Director for the record. Going to go ahead and start with our voting commission members today. When you hear your name, please identify that you are present today. So starting with Commissioner Bio-Curry Winchell.
Present.
Thank you. And Commissioner Walter Davis. Okay. Commissioner Andrea Peterson.
Present.
Thank you. Commissioner Bethany Sexton.
Present.
Thank you. Commissioner Wendy Simmons.
Present. Good morning, everyone.
Good morning. And then Commissioner Behunin, Commissioner Flo Khan, and Commissioner Marilyn Kirkpatrick all notified us that they would be absent and excused today. Chairman Khan, I forgot to ask for your name.
Present.
Thank you. So that does mean we have 5 or more members present, which means we have quorum. We can continue. Really quickly, just want to acknowledge our state representatives as well, our ex officio non-voting members. If you could please let us know if you're here today. Director Richard Whitley.
Here.
Thank you. And Executive Officer Celestina Glover. Okay, and then Executive Director Russell Cook from the Silver State Health Insurance Exchange.
Present.
Thank you. And I did receive a notification from Insurance Commissioner Scott Kipper. He would be just a few minutes late, so we'll mark him present once he joins. Chair Khan, that concludes roll call, and we have quorum. We can proceed.
Yeah. Thank you. The next item on the agenda is public comment. Public comment is limited to 3 minutes. Do we have anyone for the public comment?
Thank you, Chair Khan. So Joseph Filippi again for the record. So if you're joining today to provide any public comment, you may raise your hand if joining by computer through the Teams platform. If you're joining by phone, you can just press *5 to raise your hand and we'll call upon you. So seeing a few people's hands raised, starting with Christina Kovacs. If you can go ahead and unmute, you have 3 minutes.
Good morning. Thank you for letting me make my comments this morning. My name is Dr. Christy Kovacs. I am the Chief Clinical Officer for Behavioral Health Solutions. And I wanted to comment this morning on a recommendation that was made that we saw in the Patient Protection Commission regarding the BCCP, which is a program in the state of Nevada that provides additional reimbursement for complex behavioral patients in nursing homes. And the public comments or the recommendation I felt had some inaccuracies. So I just wanted to address that in a public comment. And I wanted to focus on in the recommendations, there was stated that the program didn't provide services and that it wasn't effective in doing what it was supposed to do. And this program actually does provide a great deal of services to these patients. Through this program, we are able to provide psychiatric medication management, one-on-ones with patients. We do care planning where we work individually with the caregivers for difficult patients and teach them interventions, person-centered interventions. We provide all manner of care. And through the provision of this care, we've been able to show the efficacy of this program and the savings to the overall healthcare system. Because of this program, we're able to transition patients out of the hospital that are very difficult to place previously, and then provide them with all of the wraparound services that they require to stabilize them in the lowest cost setting. And in doing that, we've been able to collect data in Nevada to show that And people in the program, patients in the program, were sent to the ER 72% less than those that were not in the program that had an equivalent psychiatric diagnosis. There is also a drastic decrease in inpatient admissions for these patients because of all of the services that they get and the support that they receive. So we think it is a very effective program, and it ensures that these patients have access to all the care they need to improve the quality of life and stabilize them in the best setting that is appropriate for them. Thank you.
Thanks for your comments today, Dr. Kovacs. So moving on to our next person, we have Lisa Marie Pacheco. Please go ahead and unmute. You have 3 minutes.
Good morning. My name is Dr. Lisa Marie Pacheco, and I'm a member of the Executive Board of the Nevada Action Coalition for the Future of Nursing. Nursing is in crisis across the nation, and Nevada is not immune. The shortage of bedside nurses and staffing shortages leads to patient safety concerns and must be solved. I could spend my time rattling off statistics, but you know as well as I do that no matter what formula you use, the bottom line is Nevada does not have enough bedside nurses to ensure safe patient care and safe staffing. The nursing shortage is generations old. As a nurse executive with over 33 years of experience from bedside to boardroom, I entered the profession during a nursing shortage, just as my mother had in 1957. The complexity of nursing means there's no simple fix to this growing problem. However, one best practice that is showing huge progress for nursing are state nurse workforce centers. For over a decade, the Nevada Nurse Workforce Center programs have addressed professional education, coaching, feeding the pipeline to nursing, and addressing retention through resilience and recovery efforts. In the spring of 2023, the Workforce Center accepted the invitation to join 40 other states in the National Forum of State Nurse Workforce Centers. In 2023, John Packham's team released Addressing Nevada's Nursing Workforce Shortage, a Call to Action, with the recommendation to, and I quote, fund and support a statewide Nevada Nurse Workforce Center. The center will serve as a hub to advance nursing education, practice, leadership, workforce development, and policy in Nevada. The Nevada Nurse Workforce Center programs have supported with soft money from grants and galas. Now is the time to invest in nursing and offer a sustainable nurse workforce center for Nevada nurses. It's imperative to have a commitment of funding that invests in the Nevada Nurse Workforce Center and the future of our nurses. We respectfully request your support of the Nevada Nurse Workforce Center with the provision of sustainable funding. We've submitted a packet for your review, and I'm available for any questions. And I thank you for the opportunity to speak this morning.
Thank you. Do you have anyone else, Joseph?
Yes, thank you, Dr. Pacheco. Kim McFarland, please go ahead. You have 3 minutes.
Yes, my name is Kim McFarland. I'm a physician assistant currently licensed in Utah and Idaho. During COVID and the emergency proclamation, I was able to practice virtually in Nevada as well. This opportunity was eliminated when that emergency proclamation ended. I work for a virtual practice called Connect Care with Intermountain Health. We're a 24/7 practice that employs about 30 providers who are physician assistants and nurse practitioners. Our nurse practitioners can provide patient care in Nevada. Our physician assistants cannot provide care in Nevada. This is due to regulations restricting PA practice in Nevada that no longer exist in neighboring states and most of the surrounding states in the Midwest or in the Western United States. Utah, Idaho, Arizona, Wyoming, Oregon, Montana are all near states that have less restrictive practice environments for PAs than Nevada does. This allows employers much greater flexibility when employing PAs in those states. My group alone saves approximately $100,000 per year, and now that was previously paid as supervision fees to physicians. This money can be reinvested in providers who can provide direct patient care, providing more access to patients. Utah has demonstrated a strong practice that autonomy has not harmed patients and has no disciplinary issues with PAs brought before the PA board since the passage of our bill allowing more autonomy. I would encourage Nevada to look at similar legislation for their PA licensing to allow increased patient access for PAs or patient access to PAs to improve patient care and help deal with the healthcare shortage that is prevalent throughout all states.
Thank you. Appreciate your input. Do we have anyone else, Joseph?
Yes, Dr. Khan, one more. Thank you, Mr. McFarland. Steve Messenger, please go ahead. You have 3 minutes.
Thank you, Joseph. Good morning, Chair Khan and members of the commission. I'm Steve Messenger, Policy Director for the Nevada Primary Care Association. We represent the state's federally qualified health centers known as FQHCs or community health centers. Our members provide high quality primary care integrated with behavioral and dental services to more than 116,000 Nevadans in medically underserved areas and populations. This network serves more than 45,000 Medicaid patients, making our health centers one of the largest providers of primary care in the program. You may know FQHC's Commissioner Walter Davis, CEO of Nevada Health Centers. We're grateful for this body's recognition of the need for additional investment in the health workforce. Here are our recommendations for your proposal. Number 1, investment should prioritize the production of primary care providers. Nevada is ranked at the bottom of population provider measures, and it shows in measures of access management of chronic disease, cancer screening, and vaccination rates. We as consumers, patients, and constituents perceive overall access to care based on the availability of primary care to us. It is the key to the engagement that drives better outcomes and lowers costs. Primary care providers need your help to get out of the compounding burden of working in such a profound shortage. There can be no fruit from the promise of primary care while unending demands on the providers do not meet the need of even the most acute patients. A final critical note about primary care. We believe it is the path towards greater health equity when it ensures that every member of the community has a trusted provider to ensure their access to every part of the healthcare system. Number 2, state investment in health workforce training should be directed to facilities that serve Nevadans with existing barriers to access, such as type of insurance, income, language, or geography. Community health centers are ideal because they are mission-driven and focused on integrated primary care. This is the most innovative model that a provider could train in while specializing in primary care, and we believe that a program could be enacted that is very attractive to potential trainees. Number 3, programs should be set up end-to-end so that training takes place in primary care practices in Nevada. Number 4, and this is crucial, any investment should go beyond the production of physicians to include the other primary care providers. Advanced practice nurses and physician's assistants, such as our previous speaker, are the more important, economical, and available components of Nevada's primary care health workforce. Any proposal should prioritize resources to expand training opportunities to them. Number 5, covering the costs. We suggest commissioning a program proposal from the existing stakeholders, that is, schools of medicine and nursing, area health education centers, schools of public health and workforce offices, such as the Office of Statewide Initiatives, facility representatives, such as NVPCA and the Nevada Rural Hospital Partners, and Nevada Medicaid. These stakeholders can be funded to propose a plan that covers costs for the trainee, the education, and the training facility. Stakeholders should work together to maximize available federal match in design and implementation, and they should propose an investment package to the 2027 legislature. Thank you for your important work, and please invest in primary care.
Thank you very much. Appreciate your input. Do we have anyone else, Joseph?
Thank you. If anyone else wishes to provide public comment, please raise your hand or press *5 if joining by phone. Chair Khan, I am not seeing any additional requests for public comment.
All right, thank you. Move to the next item on the agenda for approval of minutes. Do I have a motion to approve minutes? These were sent ahead of time. I presume you've all had a chance to read them.
Mr. Chair, Wendy Simmons for the record, I move approval.
Is there a second?
I can second that. This is Andrea Peterson.
Thank you. Any opposed? See none, so the minutes are approved. Coming to our main subject for today, item number 4. This is for possible action. Review and discuss and approve BDR topics for submission for the Nevada legislature. I would request our Executive Director, Joseph, to update the commissioners on the currently selected bill draft requests and subjects or topics. We'll have the opportunity to review drafted language and vote to approve. If we so choose, modify, or look forward to a different topic besides this or in addition to this. We have a deadline to submit this by September 1st, which is barely 2 weeks from now. So I would hope that we are able to come to some consensus on these BDRs so that the Legislative Council Bureau can vet it and tweak the language from there. Thank you. Let's proceed, Joseph.
Thank you, Dr. Khan. And I'm just going to note that I think I saw that Walter Davis joined the call. Walter, can you confirm you're on?
Yes, thank you. I'm present.
Perfect. We'll mark you present. So thank you, everyone. Good morning. Joseph Filippi for the record. I serve as the Executive Director for the Commission. So today for agenda item number 4, the Commission is going to review and discuss possible bill draft requests to submit to the 2025 legislature. So they have 3 BDRs that you can all propose. BDR topic 1 relates to Medicaid Healthcare Workforce Development Fund. This BDR topic, the intention of the topic is to authorize the Division of Healthcare Financing and Policy to establish a fund for graduate medical education programs that could leverage Medicaid federal funding to support the expansion of these programs in order to increase the capacity and the size of the state's healthcare workforce, in addition to increasing access to care for Medicaid recipients. So this topic was unanimously approved at the last meeting of the Patient Protection Commission in July. And this slide here has the draft language as it is currently. So the draft language was developed in coordination with the Division of Healthcare Financing and Policy and has been shared with each commissioner for review and discussion today. So before moving on to the next BDR topic, I will ask if there are any questions or concerns regarding the proposed language.
So I believe everybody received, all the commissioners received this proposed language. So if anybody has any questions or other considerations in language, additions or subtraction.
Andrea Peterson, go ahead.
Yeah, thank you. I'm just wondering if we can maybe add a verbiage in there to ensure adequate staffing within Medicaid for this. Did they bring that up or not? I just don't want to add to somebody else's workload.
That is a good suggestion, Commissioner Peterson. And I did work with the division to help draft this language. They didn't mention this, but that could be something that is, I guess, added to the fiscal note during session. So once this BDR is submitted, because it does impact the division, they might notate that they will need additional staffing or funding just to implement this bill. So definitely that's something I think the division can highlight perhaps at a later point.
Thank you. Anyone else have any thoughts? See any, Joseph?
Not seeing any hands raised, but feel free to chime in, commissioners.
Joseph, this is Wendy. I do want to support the recommendation that was just made. I know you mentioned that there would be an additional note in the proposal. It might be a fiscal note, but we all know sometimes fiscal notes kill a bill. So the consideration of actually putting the language into the bill, gives credence to the expectation that the commission would like to have for the serious consideration of it.
Thank you, Commissioner Simmons. No, I think both of you make a great point, and what I'm willing to do is take that feedback and perhaps we can add an additional sentence or verbiage in here somewhere to highlight that, provide staffing in order to help implement this measure.
But I do want to make sure that's something that as part of the motion, when we actually finally have a motion for this, we perhaps include that as a motion as something that we add. We don't necessarily need to have the exact language, but just words to the effect of what it is that you're looking for. And as somebody who represents Nevada Medicaid, I appreciate that because I know that Nevada Medicaid has had its duties expanded significantly over the last bunch of years, and that has put some stress on staff. Thank you.
Okay, that makes sense. Any other thoughts?
Commissioner Davis, go ahead.
Yes, hi. I just wanted to just confirm that when we talk about eligibility for a GME, that is also in consideration of a teaching healthcare center program. Would that be something that's tied or associated in that same vein?
I didn't understand what exactly was suggested.
Well, the suggestion is making sure that there's additional funding. When you talk about, eligibility for graduate medical education programs, does that include a teaching healthcare center program that for additional funding or support to establish those for healthcare center organizations?
And this is Joseph Filippi for the record. It's my understanding, Commissioner Davis, that our intention for this BDR is to kind of keep it broad, and to answer your question, I would think yes, that funding could be allocated to a accredited, teaching health center GME program. I think this is meant to establish the fund for the state to invest in various types of GME programs. And so I would think as long as the teaching health center GME program is accredited and passes all the regular requirements, I don't see any issue with why this couldn't help fund those types of programs.
Okay, thank you.
Thank you. Anybody with any other thoughts? So Joseph, you want to sum up what was just discussed that we are going to incorporate?
Sure. So I think I'm willing to have a commissioner make a motion, but I believe the motion is to approve the language as drafted, but also work with the division to ensure that any staffing that is needed is incorporated in the BDR prior to submission to the legislature.
Does that sound right to all the commissioners? All right, so then we will entertain a motion to approve as proposed.
I so move, Commissioner Wendy Simmons.
Is there a second?
Walter Davis seconds.
All right, any opposed? None, so the motion carries. I appreciate this is probably a historic one. The last commission's term, we spent several meetings approving language on one BDR. So this is great. I like that. Right? Richard is laughing. He knows what we went through. So thank you very much, all the commissioners. So you move on to the next item. Joseph, you want to continue?
Yes, thank you so much. Joseph Filippi for the record. So the second BDR topic relates to increasing Medicaid reimbursement rates with a targeted approach. This topic was also approved at the last PPC meeting as one of your 3 BDRs. And the second BDR topic's intent has several different sections. So first, the intent is to increase Medicaid reimbursement rates for physicians, which also applies to APRNs under parity laws, by another 5% this next biennium, with an additional 3% bump for any Medicaid covered services rendered to recipients in rural areas, and then an additional 3% bump for providers who participate in value-based payment models. So secondly, the BDR requires the division to seek federal authority to establish accountable care payment models that promote high quality and coordinated primary care. These models will include incentives and value-based payments for providers and participating healthcare organizations that meet healthcare quality standards. Lastly, the measure requires the division to survey providers of healthcare each biennium, requesting recommendations on how to improve the provider utilization and billing experience with Nevada Medicaid. This BDR topic aligns with the PPC's goal to address healthcare access, quality, and affordability. It also aligns with the governor's executive order to increase provider reimbursements that incentivize and reward for a better quality and value of the taxpayer dollar. So this slide has the draft language. It was also developed closely with the Division of Healthcare Financing and Policy, and it has been shared with commissioners for review and discussion today. I'm happy to open it up for questions from any of the commissioners regarding the language. And please go ahead, Ms. Peterson.
Yeah, I've had some questions. So one of the big things that I see not being included in this is the impact with managed care. Is that something that you can speak to? You know, so really, and specifically, like, how is the accountable care organization going to function in relation to managed care?
Is Stacy Weeks on the call, or anyone from Medicaid? It's my understanding that I believe managed care organizations could also be included in the value-based payment models as long as they I believe it would be a voluntary process. So managed care organizations, providers, and different healthcare organizations could enroll into these value-based payment models and to receive some of the benefits.
Yeah, I think we need clarification on that. Just two more things I noticed, and we even had it in public comment today. So I noticed that it's really APRNs and physicians. So I don't know if there's anything else around other provider types. So I have a question with regards to that. And then just kind of, has there been any discussion on what the impact on the budget would be of this?
And this is Joseph Philippi. I'll try to respond to that, Andrea. So as far as the budget goes, yes. So this would be an enormous investment from the state. As we talked about last meeting, the state has very limited areas where they can pull new sources of funding from. And so last session, it's my understanding that there was a similar increase for physicians, around 5% increase, and that cost close to $100 million at the end of the day once we receive the federal match. And so this BDR is seeking to give them an additional 5%, but then also providing incentives for rural health, rural care services, and any value-based payment model services as well. So I believe if I hear you that there's several provider types that could use an increase. I think that this body has discussed just the high need for primary care investment, and just knowing that physicians and APRNs and they are such the sole providers, I would say, for primary care. I know there's many other provider types, but there's so many areas also within just the physician reimbursement code. There's several areas of types of physicians that would be impacted through this rate increase. So I hear you that there are other areas where rate increases are needed, but I think just this is also a huge investment if it was to move forward as well.
Yeah, I will say I think that it really does need that wording in there, just kind of clarifying the impact with managed care.
So a couple of things on that. The Medicaid reimbursement, obviously the state has some control, has leverage in increasing, decreasing, etc. There are managed care organizations which provide Medicaid services. Medicaid has outsourced major amount of its services to managed care organizations. And then there are non-Medicaid managed care organizations. So if I hear you correctly, this should be applicable to the Medicaid managed care also, because Medicaid fee-for-service is a very small fraction of services. Correct me if I'm wrong, Richard Whitley, as to what is the percentage of Medicaid population that currently goes through the managed care product?
Richard Whitley, Director for Health and Human Services, for the record. it's primarily focused fee for service in rural Nevada right now, with a plan to move to managed care, leaving really the age, blind, and disabled as the population that will utilize the fee for service model.
So, as I recall, this was supposed to be across the board for all providers. Joseph, you might recall, we went through that language back and forth, not just the rural area, primary. And number two, if we are looking at only fee for service, the impact will be a drop in the ocean, because the large majority of the population is with managed Medicaid.
Mhm.
So if it is not going to affect those providers, that would also be of concern. And that's why I was interested in knowing what percentage is in fee for service, or the other way around, what percentage is in managed Medicaid products. My understanding is, if not more or less, around 90% signed up with managed Medicaid, and fee for service Medicaid is left with the more sicker patients, which no managed Medicaid wants to take on.
Yeah, and I understand that. I think it's just trying to understand the workflow of what this will look like with managed care.
Can I
Right.
jump in as well?
Yeah.
Yeah,
This
so
is-
just follow, and I agree with you, Andrea, what you're saying. My view is it should include the providers in the managed Medicaid product.
I think that gets really tricky though, you guys. So this is Bethany Sexton for the record, because the funds that go to the MCOs are capitated actuarial amounts on a PMPM basis. And then the MCOs have to go and negotiate rates with individual providers. So I'm glad that Stacy appears like she might be on here, but I think it gets pretty
Yeah, can
technical
I
on how.
Jump
Yeah.
in. Yeah,
Yeah.
so I apologize. I've, as usual, triple double booked again. So are we talking about, so I can't speak to the procurement, but I can tell you that most of this money will be directed at the fee schedule. So if we set a fee schedule, we are going to require MCOs to pay that fee schedule. So it's a little different than what you're talking about, Bethany.
So at a, can maybe.
At
can
a
you just clar-
minimum, there's
Yeah,
fee
at a
schedule.
minimum. Okay.
Okay.
Does that answer your question, Commissioner Peterson, regarding the managed care?
Okay, so this essentially does it. There's not any specific wording or anything that needs to be included in here.
I mean, if
Around.
you want to, for safety purposes in future years, right? When people move on and leave, you could put in here that the state will pay the fee schedule for these provider types, at least at a minimum, including
Yeah,
managed care plans, and that will be a directed payment, and we can do that.
Perfect.
Yeah, I think that makes sense to me, at least. And as long as we are covering all providers, not just rural providers. Because there is a crisis in urban population, certainly in Las Vegas. We know physicians beyond primary care, specialists in outpatient practice and otherwise, refuse to take Medicaid patients because of the
Can I ask an additional clarifying question,
Yes.
Stacy? In terms of, I'm assuming then that if that's a mandate, that as a part of that procurement, the capitated rates would be adjusted actuarially to ensure that those.
Yes.
Yeah, that, I mean, the funds are also flowing to the MCOs, and that sort of the insurers are also not holding the bag on being able to have to pay that at a minimum.
Yes, anytime we do fee schedule at a minimum, it affects our cap rate. So again, this will have to be paid for in the budget bill. Mhm.
Okay, thank you.
That's very helpful. Any other thoughts? Joseph, I remember there was somewhere regarding all providers when we looked at some of the language. So I just want to make sure it includes all providers, not just providers.
And so can you clarify, Dr. Khan, because I think as we kind of discussed there, we couldn't do a across the board increase on every single provider type that Medicaid reimburses just because of the cost associated with that. But this BDR is focusing primarily on physicians and APRNs, but then additionally adding, those services in the rural areas. And if once these value-based payment models are established, an increased rate for those participating providers as well.
No, I agree. I'm talking about all physician providers, primary
Yes.
care service
Yes.
providers. What I'm talking
Yeah, so
about.
specifically, I believe the intent is to have this pertain to the provider type PT code. I have it here, sorry. PT code 20, which has several different types of specialties under the physicians and DOs, and in addition to the APRN code as well. So if
It's a
you're
whole list that we can provide members afterwards. It's huge, so.
Okay.
I will
Yeah.
just tell you, last year when we just did the physicians, it was 30, this 5% was 37, just for 5%. So if you add on the 8% for the rural and all those things and value, it's gonna be more, but just for the physicians, it was 37 million state general.
It's a drop in the ocean.
About 70 to 80 million a year with total expenditures. So just, understanding the size of this is a big investment. So I know it looks small with 5%, but it is a huge investment in providers. It's not like a small amount of money.
No, I agree with you. I feel very strongly is healthcare needs to become a priority in the state in budgeting processes, because that impacts every single individual. More so in the lower income category people, where they lose access. We have providers, but they don't want to see them. So that's a huge challenge. So yes, I agree with you that every percent adds, Stacy, as you said. Hopefully the legislature will take into account the priority and significance of it. Any other comments? So Joseph, you've got the.
This is Dr. Bio. I just wanted to add, with that overlay of in the rural communities, the places that are serving those that are social economically challenged. And so as we heard comments about the need for more providers throughout to really serve those communities or primary care, we should also historically look at some of the offerings that have happened to APRNs, different clinicians, when we improved or increased access, those clinicians didn't actually work in primary or serve the Medicaid population. So as we look at, access and having this offering, it's important that those clinicians actually are partaking in that type of care versus what we've seen in the past is with that improved access with certain groups or APRNs and so forth, it's been on different specialties, whether it's been more of a boutique or aesthetic. We haven't really seen a huge influx into that group of what we're trying to serve.
Dr. Khan, can I just make one quick comment? I just wanted to tell you a little, if it's okay, about some of the experience we already have with the 5% we just implemented.
Right, sure.
So we're already seeing sometimes I will be honest, I'm a little skeptical if rate increases actually work, right? But I will tell you the 5% that we put in, or the governor put in his budget last year, that was passed and signed into law, that we finally are starting to recycle claims back to January 1, that we finally got approved from CMS. We are already seeing a significant increase in utilization in these services. So, and it's for physician services, dentist services, as well as APRN. So I just want to say there has been an increase in uptake, and it's exciting to see that it could be working in this area. So I just wanted to note that piece.
Yeah, thank you very much. I think that's crucial information for our purposes, Stacy, that whether it's working or not, and that's very valuable input that you just gave us, because data matters. No matter how we look at it. Any other thoughts before we move? Joseph, you have anything else to add?
No, Dr. Khan, appreciate the discussion.
I do think we need to add the line to ensure for posterity's sake that it flows through to providers.
Yeah,
so however
I
we
agree with
I will
that.
add that. Bethany will add that in and send it out to the group. There's simple language
And
we
this
can
is-
add.
This is Dr. Bio for the record. I agree with that.
All right, thank you very much. Any other thoughts before we move beyond this? And before we move, I'd be remiss if I do not recognize Stacy. I mean, I've been in this business working with state legislature for 40 years, literally. And to put it bluntly, when I talked to her the last time on the phone, what I've heard from others, I haven't come across somebody in the state so knowledgeable and so into the weeds of every little question you might ask, and she's ready with an answer without saying, I'll get back to you. So Stacy, thanks a lot. We're really fortunate to have you at the state level and for the people of Nevada. And I mean it because, as I said, I speak from experience.
Well, thank you. I'm honored to be here and to help everyone move this forward. So thank you, guys.
All right, Joseph, if you don't have any other hands or suggestions, we can move on to the next subject. You got the gist of the language that needs to be added.
Yes, and before we move on, I don't know if we need like a motion from the group just to include the additions discussed today.
Yeah.
To be consistent, let's go ahead and just to be consistent, let's have a motion and formal vote, yes.
We will. So I would entertain a motion to approve this BDR proposal with the language to be modified as mentioned. We have a motion.
I move. This is Bethany Sexton for the record.
Walter
All right.
Davis seconds.
Okay, we have a motion and a second. Any opposed to it? I see or hear none, so the motion carries. All right, Joseph, let's move on then.
Thank you, Dr. Khan. Joseph Filippi for the record again. Moving on to our third topic for the day. So for consideration as your final BDR, since there was interest and discussion previously regarding joining licensure compact, specifically the nurse licensure compact, I thought it would be helpful to provide information on additional compacts for the PPC to consider. Interstate licensure compacts improve healthcare licensure portability. They can expedite the process for essential providers to become licensed in the state, and they also increase the pool of providers available to serve Nevada patients. So the intent of this topic would be to reduce barriers for licensed providers to practice in Nevada by authorizing the state to enter into multiple licensure compacts with other states, including the nurse licensure compact. The intent of the BDR would be to join certain licensure compacts to remove unnecessary barriers for recruiting and retaining providers, support relocating military members and family, improve licensure portability and streamline the onboarding process, improve access to care, and ultimately address the workforce challenges. The table on this slide outlines compacts Nevada is not currently participating in, the number of states that are in each compact currently, and the provider types associated. I will note that we left off social work and the counseling compact specifically just due to hearing that other legislator and another policy board are pursuing those compacts through a separate BDR. So just thought we would focus on these other ones. So at the compacts here, so moving from this larger list to this a little bit smaller list, the compacts on this slide are possible considerations for y'all to consider. We reduced the list down just due to the these compacts have the most states already within the compact. As you can see on the last slide, there's a few that only have a handful of states and have not been activated yet. So just for everyone's awareness that certain compacts have a certain state threshold before they're activated. So all of the compacts on this slide are currently activated. They have a majority of states in them. The newest compact on the list is the physician assistant compact at the bottom. It has only 13 states currently, but there's been several states joining over the last few months, and it seems to be catching steam. So just thought that this list here, it would be a good list of compacts for y'all to consider, including in a BDR. I did confirm that It hasn't been done previously, but there is a possibility to include multiple state licensure compacts in a single BDR, as they all relate to a single topic, which would be, licensure compacts or occupational licensure. So there is that possibility to include more than one compact in a BDR. And so, from this list, we went ahead and just drafted proposed language, which would include enacting those 5 compacts, which include the nurse licensure compact, physician assistant compact, physical therapy compact, audiology and speech language pathology, and occupational therapy. I will note that just yesterday I was looking at the new BDR list. So recently legislators have been already submitting BDRs for the next session, and there was actually a BDR submitted for the occupational therapy compact. So completely leave it up to you all if we were to move forward with having a BDR with several compacts, if we wanted to include that still or take that out potentially because it's already been selected by another legislator. But ultimately just wanted to open it up for discussion today on, if this is a topic that you all are, you have already previously notated that you're interested in it. So I just thought that I would pull some information on compacts for y'all to consider and discuss as your final BDR.
Thank you, Joseph. If I may, just the whole purpose of considering the BDR, the compacts, was that will it help get more providers to the state more efficiently and quickly, and particularly the physicians and nursing shortage that is pretty severe, as we all know. Having said that, I had talked to Joseph the other day to find out, being a part of that compact, has it really helped the state in getting physicians or other providers? We do not have a nursing compact right now, correct? Joseph?
That is correct. Yep. The compacts Nevada currently has the physician compact, the psychology compact, teachers compact. There was a EMS compact passed last year. I might be forgetting one more, but so there's a handful of compacts we're already in. And as go ahead, Dr. Khan, I'll let you continue.
So basically, having said that, if it really helps us in getting and recruiting providers to the state quickly, that's the whole idea. I went over at some length with Joseph, and he got some current information on the physician licensing board. And the other part of the compact, the physician has to be a part of the compact to begin with and pay $700 to be a quote-unquote member of the compact. Then the states that are part of that compact, when he applies to that state, the state supposedly gets all the background information that the compact has vetted and transfers it to the state. Question comes up is that once they're applying for Nevada as a part of the compact, I'm told that 50% of the applicants are coming through the compact. However, they have to pay the fees for Nevada license also. Well, the whole fee is for background check, vetting, and all that stuff. If that has already been done by the compact, what is the state board charging the provider for just a clerical work where they get all the information, look at it, and say, go ahead? And the other thing was, how soon does a physician coming through the compact gets the license? Currently, when the state does its own vetting, it takes an average of 3 months and sometimes 6 months to get a licensed physician in the state. If they're coming to the compact, Joseph, refresh my memory, how soon are they getting a license in the state, a full license?
1 to 3 business days.
Right. So having said that, was that a permanent license or a temporary license?
That's a permanent license. So, and I believe, compacts work a little bit differently depending on the compact, but from reaching out to the medical board recently with some questions from Dr. Khan, they did say that how the physician compacts work is the physician has to basically enroll into the compact and then select the states they wish to practice in. And then the compact or commission over the compact, they do the vetting process, they do the background check, they review all the, residency history materials, everything they typically have to do with each individual board. They conduct that review process. Once they've vetted that out, they then issue a letter, a qualification letter to various state licensing boards saying they've passed our process and they wish to practice in your state. And our medical board in the state automatically issues the license based upon that letter. They don't conduct a separate background check or do anything else. I did look at the compact's website and so they have to pay, like Dr. Khan indicated, a $700 fee to join the compact, the physician does. And then it looks like there's a separate fee for each state that they want to practice in. However, and I can get clarification from the board. I'm actually still waiting to hear back from them, but I believe it's a reduced fee as compared to if they were to apply for a license specifically just for Nevada. So I believe it was $400 for an MD, $300 for a DO if they're applying through the compact for Nevada. And those fees differ by the state they select. But it's my understanding that it's definitely a streamlined process. It doesn't take 3 to 6 months to get a license in Nevada. Once they select that, it's issued almost automatically. So there is benefits in that, and as the medical board indicated that 50% of new licenses that they're issuing is coming through the compact, and so I think that shows that there's an interest for one in physicians wanting to utilize compacts, and so I think that I believe we have representatives from the nursing board here. If there's specific questions on that compact, I know we've received a lot of information on that. It's my understanding that compact operates a little bit differently, a little bit more similar to a driver's license scenario. So just as we apply for a driver's license, once we get that, we don't have to get a separate license and get approval from each state DMV we want to drive in. That seems to be how the physician compact works. Where a nursing compact, once they get that license or that compact license, they can then freely practice in any compact state without having to pass go, without having to contact that state licensing board. Doesn't mean they don't have to follow the state rules and regulations that apply for Nevada, but they wouldn't have to apply and pay for a separate Nevada license to practice here. So it really, I think, depends on the provider type and the compact on how it operates. But truly, it does look and appear, looking at the data and the information we've received, that it definitely streamlines the onboarding process and eases the process of bringing more providers to the state. So, Walter Davis, you have your hand up. Go ahead.
Yes, I certainly support, the compact, but what we must continue to improve ourselves on is the credentialing process in total. That's still a major challenge. It takes way too long for any of our providers in here. So if we wanted to really make an impact, we have to add and address the credentialing component in general.
If I may take the liberty of chiming in, I served on the medical licensing board for 8 years in my previous life here. So having said that, the challenge in direct applicants is that the medical board requires the applicant to get confirmation of his medical school graduation, his residency, and wherever else he or she may have practiced before applying here. And it has to come from that entity directly to the medical board. So the applicant then writes to the medical school, the dean is long dead, et cetera, and then they start looking for it, and takes days and weeks. And then he goes to his first residency program chief, who is also no longer there if it's a senior physician, and they take forever to respond to the medical board's letter requesting the information on the resident. Then if he has done a fellowship, he has to get that information directly to the board. And then if he has practiced in 3 states, he has to get information from them directly to the board, certified mailed. And if it's an international graduate, which are larger and larger in number, you can imagine he has to write to the medical school overseas in England or India or wherever, and then get that information, which may take 6 weeks. They do not accept certified notarized letters of any kind. And that is the reason why the delay takes. We have in my tenure there denied licenses to some of the most highly qualified professors from England and one of them from Florida, including a person who had applied to be the chairman of the Department of Medicine at the medical school because he couldn't get a certain document from where he had graduated, and it dragged on until the school no longer offered him the position because it was taking too long for him to be licensed. So those are some of the challenges that delay, to Walter's point, forever. What can be done differently? This subject has been discussed also for at least 40 years in various legislative sessions, whether the states should give reciprocity, which is different from the compact, which means if I'm licensed in California, where everything has been vetted and stuff, then the Nevada board would get all the information from California about me. And once they get all that, they would issue a license. That is the reciprocity process. That is for every applicant, the Utah or Arizona or New York or wherever. In other words, they're accepting the compact's vetting and giving it in 1 to 3 days, but we are not accepting the vetting that the individual has gone through in any other of the 50 states, and they have to go through the whole process from ground zero. So that's the background, and the issue is reciprocity, whether we want to go there, and that would be the ideal situation. There are some states who do allow reciprocity, and you get the license based on your license in another state.
Yes. And this is Walter Davis for the record. Again, again, on the credentialing side, with the payers, just a scenario that we deal with every day. If once they get the licensure, and then we have to wait for all the credentialing before they can see certain of the payers' patients, and it takes a long time. And what we end up doing as the FQHC is we have to hire them because there's such a shortage. We don't want to lose the candidate. And then they only can see our slide patients, in our programs. And so it makes it even more difficult because we're having to pay the salary, but they can't really see all the patients that we have from the payer component. So again, credentialing in the state is just very, very slow. And so it really puts a burden on the healthcare centers in general.
And that is true.
This is
The commissioners also.
Go ahead, Phil.
This is Dr. Bayokuri-Winchell. I wanted to add on to what Walter mentioned. So it's compounded, as you mentioned, Dr. Khan, of course, that licensure piece. But then once they have their licensure, then we're waiting about 90 to 120 days to even allow them to be able to be seen. And so it can be such a heavy lift on those employers, those FQHCs, to even get the provider to be able to see those patients. There's a roster, they're waiting, but there's 2 parts that are adding to the delay. And sometimes it can take, we've had clinicians where it's actually taken about, from the licensure to the credentials, about 6 months to even really get that ability so they can see a full panel.
And that is absolutely true.
Can I just jump in from the payer side? There is background there. So payers have accreditations that they have to maintain, NCQA accreditations and other things that have requirements around the credentialing process. And so I think while I totally hear you guys on the delays that can create, I think there are other requirements that payers are being held to. And so when we think about some of the products that we even offer in the state, we have requirements to maintain those accreditations. And so it's sort of this, one layer on top of another that would have to be impacted to, I think, move the needle on that. So I just wanted to put that out there.
You're right. If we could cut down the 3 to 5 months on the licensing board, and then the payers or the hospital credentialing takes another 3 months, it'll really be 3 months. If the board part is reduced 1 to 3 days, like they're doing it for the comp. So
every little bit helps, right?
And that's the point. So that can only come if we allow reciprocity to cover all 100% without having the physician pay to the compact and then a reduced fee to the state again to get the license in 1 to 3 days. So I'd like to hear from the commissioners their thought on the reciprocity, which would cut down this 3-month period so that the managed care in the hospitals will only take about 3 months to do their due diligence because of their Joint Commission and other people in the hospitals and managed care organizations, oversight entities.
Chair Khan, I was going to say,
Sorry.
yeah, I was going to say, I know that we even had discussion the last time around the nurse licensure compact, and that it is a controversial subject that's really been attempted multiple times. I think, is there a question, is there an interest in addressing reciprocity? Because I too have heard, some of the barriers with physician licensing that Chair Khan has discussed. So is that something that we could, is that something that could be addressed through a BDR, I guess, is the question?
It could be. The only way it will happen if the commissioners want to go that way is through a legislative process, basically.
And so may I ask, it sounds like you all are starting to have, more of a license reciprocity conversation. So should we first, I guess, vote or discuss if we want to move away from licensure compacts, or if there is still members who are supportive of potentially using a BDR on compacts to help streamline the onboarding process? I know that, if there is an interest in licensure reciprocity, more than happy to, as we've talked about other recommendations, we can definitely include that and look into that further as a formal recommendation from the commission in regards to how to address the workforce challenges of the state. But I guess, should we first, before moving on to other topic areas, should we decide if we want to move on from licensure compacts or not?
Thoughts from the commissioners?
Joseph, this is Wendy Simmons, and I know Bethany has her hand raised. I can't raise my hand for some reason. Some of my screen isn't working appropriately, so you said to go ahead and speak up. Personally, as you provided us so much information, wonderful data, comparisons from other states in the compact discussion, I find myself shocked and sad that Nevada is so behind the 8 ball in even considering the discussion of the compact tool as a segue to at least allow the entry of some of the practitioners that we have. And when I look at 40 states that have approved the nursing compact, out of 50 plus states, right? And we're sitting here having this discussion year after year. I do personally like the fact that you pulled all this together for us and that you also served up the bundling of compact vehicles in the other practitioner areas. And so as just a member of the commission, I would be standing in support of this being something that we would consider as our third bill, knowing that through the legislative hearing process, we are also going to roll over to the reciprocity discussion, which is utilized by several other licensing boards in our state. And maybe that bill would morph to be a reciprocity thing. But I think you've given us good data that allows us to at least invest in some kind of decision-making process. So thank you.
Any other commissioners' thoughts?
This is Bethany Sexton again, for the record. Wendy, couldn't agree with you more. It feels like we've done so much legwork on the compact piece that while I can appreciate the reciprocity thoughts, maybe that's, to Joseph, your point, a recommendation for future investigation and thoughts. But again, I think that we've done a lot of work around this. And if there is another opportunity to put it forward to say, we really feel like this could help the state on many fronts. And I like the idea of the potential to pull them together, because then it's sort of a unified front. We're saying we're really trying to put workforce front and center across many domains, not just focusing on one. This is a way that we could do it. So I would support continuing to move forward with it.
Thank you. Any other thoughts? I'd like to hear from all the commissioners, their thoughts on proceeding with the compact subject across the board.
Yeah, this is Walter Davis for the record. I support anything that will continue to enhance, bring in providers to our state. We're such in a critical shortage that we need to do everything we can to make sure people can get in, and our patients and our communities are taken care of appropriately. So I definitely support it.
Any other thoughts?
This is Andrea Peterson. Oh, and I think she has her hand up. Sorry. I would just say that, if we do it, that we do it intentionally, understanding that there's been barriers to this in the past. And I think unless it's presented in a way that maybe addresses those barriers, I would just hate to see a BDR, that just kind of isn't successful again.
I think
Dr.
Dr.
Biocurry Winchell, sorry, you have your hand raised for a minute. Please go ahead.
Yes, this is Dr. Biocurry Winchell for the record. I agree with moving forward with this, really getting on the train that's already been going, so we can at least do something to increase that workforce shortage, but still keep top of mind. I am in a support of the, I can never say the word, the reciprocity, because I think that's another way to really help us move forward and continue to move forward.
I think if I heard everybody correctly, there is significant appetite to at least go for the compact. In that area, my question, if that's the way the commission as a whole decides to go, then Joseph gave us a long list of all the providers that are in some compact or the other in other states, and whether we need to limit that to certain providers, nurses, etc., to begin with. And the other question is that we can't have reciprocity and compact both. We are duplicating to some extent. So if we are for reciprocity, then it'll affect, the same way the compact does, except that the physician is paying one fee, or the provider in that case, or any other board of nursing, etc., and quickly licensed within a week or so. So if the majority thinks we need to go compact subject, a question was just raised that since there is some opposition, whether we would be, quote unquote, if I heard correctly, we'll be basing a BDR because of the opposition that we are aware of in the legislative process. So we need to narrow this down. If the majority wants the compact route, then we have to, I think, in my opinion, limit that to certain most impactful licensing entities rather than a bunch of 10, 15 of them all together. And it may get nowhere with all the stakeholders having different opinions, and we may lose the whole impact of that in a compact discussion. So I would like from more. Evil.
Sorry, this is Joseph Filippi for the record. And Dr. Khan, I'll just reiterate that, I think in looking at the various compacts that Nevada is not currently enrolled in, these 5 stood out as they would address, several different provider shortages that we have. They have multiple states already enrolled in them. They've been activated. As I mentioned, the physician assistant compact would just have, it just was activated, so it might take 18 to 24 months before that's, we start seeing physicians assistants coming to Nevada through the compact, but the others have been activated for some time now. So I tried to reduce the list from, 10 or so compacts that we're not in to down to 5. As I've mentioned, the OT compact, some other legislator has proposed that forward, but it was just a single compact within a single BDR. So I would leave it up to you all to discuss, and if there is interest in using your final BDR on bundling these compacts, are these 5 compacts something you would wish to include? Would we wish to negate the OT compact since that's already being pursued in another measure? Or could we just include it and then let the legislative process continue and go forward from there? So I'll open it up for the commissioner to discuss.
Joseph, again, this is Wendy. For the record, I again express my appreciation for you defining the top 5, which have the greatest percentage of other states that have done this review and brought them forward to an action item as a state. My recommendation would be that we keep the top 5 in the as proposed and explained in the document that you provided us here. And of course, I'm the consumer advocate or the person in the field outside of the licensed practitioners. But we're long overdue to broaden the field of access to each of the providers and practitioners that we see in the list of 5. And I will gladly sit at every legislation hearing on this, if necessary, just to support something finally happening and being on the radar from the consumer side.
Thank you, Wendy. Any other commissioners' thoughts before I request for somebody to make a motion?
Can I just ask a clarifying question? So if we put forward all 5, as that works its way through the legislative process, can others take things out or break it apart? Because I think, as we know, there's opposition in potentially certain areas and great support in others. And I think we also, through our dialogue, have seen that there is great support widely across the community and with patients and others for all of these. And so I would hate for things to be able to be broken apart if perhaps we could garner support broadly by making sure that they stay together.
That's a cap questions, in the legislature, it's like sausage making, as they say. It may all fall apart or all stay there, or pieces of it will stay there. So that's the challenge we face. But in my humble opinion, we have got to start somewhere with the assumption that no matter what we propose to the legislature, it will be tweaked, modified, adjusted, et cetera, et cetera.
And I think this is Wendy Simmons again for the record. We could fully anticipate any of the boards that represent the 5 that we brought in, or other entities and influencers from outside of our good boards that do a lot of great work. We can fully anticipate that there will be opposition, but at least we as a commission have met the intent and the direction we were given by the governor to work on workforce development. And this can be a tool or an opportunity to express that we've done our due diligence and our duty, and we are bringing something forward. So,
Joe, could you, sorry, go ahead.
I was going to say, if you'd like that in a form of a motion, I was rather wordy there, but Joseph could reiterate what the motion would look like, and then I would be the first to submit the recommendation that we approve this.
Yeah, thank you, Joseph. Could you bring the commissioners up to speed? I know you've sent this information before. You received something from the nursing board, right? Regarding some opposition or not enthusiasm about a nursing compact discussion.
Joseph Philippi for the record. Yes. So,
and what
shared,
was that?
we have shared just how, in the past, the nurse licensure compact has failed to pass in the state due to opposition from the nursing unions in the state. The nursing board provided basically responses to each concern that has been raised in the past by unions. Do you have a specific question on the concerns?
And for the opposition by the nursing union.
I think we have representation from the board if Ms. Denauer or Mr. Hillberry wishes to speak to that. they can speak to some of the opposition that's been raised previously, but I will note that, they've confirmed and they have national support and information to show how beneficial the nursing compact has been in other states. And so I know that they're well prepared to speak either now or during the legislative process on addressing some of those concerns that have been raised. But I agree that we would just need to work closely with each of these licensing boards between now and when session starts, just to gather as much information as possible to support these measures throughout the legislative process. But did you want Mr. Hillerby or someone from the nursing board to speak to the nursing compact?
Somebody is here so that we can wrap up this final BDR today with full information. Is he available or?
Yes, Mr. Hillerby, are you willing to speak to the history of the nursing compact briefly? And I know you've spoken with us before on this topic.
Good
morning.
Kathy Denauer's on.
Oh,
I'm.
and go ahead, Ms. Denauer.
Good morning, Commission. This is Kathy Denauer for the record. I'm the Executive Director for the Board of Nursing. And I know that Mr. Hillerby is here and he may jump on, but I'll just be very brief. Yes, we have tried for well over 10 years to get the nursing licensure compact passed in the state. And we have met with really the only opposition has come from the nursing unions. And there are a variety of reasons, anything from worried about strike breaking to continuing education to all kinds of things. But to my knowledge, that hasn't been verified in sort of any evidence. I provided Joseph with information with regards to some general nursing union opposition issues to the compact, and we are very prepared to address those concerns as they come up. But as I said, we have tried for many, many years. In 2022, we did do a survey of the nurses in the state, and overwhelmingly about 92% of the nurses in the state are in favor of a nurse licensure compact. So it is something that the nurses in the state want. And I'm happy to address any other questions.
Thank you very much. If any commissioner has a question, please proceed. If not, then we'll proceed with the motion and see where it lands.
Chairman Khan, this is Wendy for the record. Kathy, thank you. I know I've sat at the table with you with Department of Veterans when we were also talking about this very same subject, and you've worked very hard and very professionally, and I really want to thank you for this. And I feel maybe the timing is right now. And by the way, Chairman Khan, I am so grateful and so impressed with this body, the Patient Protection Commission partners, that we're all sitting here together and trying to move things forward. Thank you all.
Most welcome. So Joseph, you are on the spot. As Wendy said, put some language that could be a part of the BDR so we can vote on it. He has agreed to move the motion based on the basic language. The only thing you had mentioned, we have to include a limited number of compacts. You put a slide on of 5 of them. So we need to make sure that we are all in agreement for potentially all 5 to be considered in the BDR.
Yep. So as the proposed language is outlined currently, this would enact multiple licensure compacts, and those include the nurse licensure compact, the physician assistant compact, the physical therapy compact, the audiology and speech language pathology compact, and the occupational therapy compact. Each of these, the state would enact and enter into the compact. And in addition, we included language to study the impacts of each compact and how it would address the shortage of nursing or the various provider types. So I know there's been a desire to see if compacts even help move the needle in any way. So each of these proposed topics would, in addition to enacting the compact, request that the state study the impact following enacting the compact. So I'll go ahead and open it up for a motion of the commission to either approve, modify, or reject the draft language as presented today.
Go ahead.
Chairman Khan, Wendy Simmons for the record. This is the last I'll talk. I would like to move that we adopt as our third BDR the proposed language that has been submitted before our commission.
Thank you. Is there a second?
This is Bethany Sexton for the record. I second.
Thank you. Any opposed? None. Joseph, do you see any hands or anything?
I'm
Okay.
not seeing any hands or hearing any commissioners.
If not, then this motion carries. Thank you very much, everybody, for, as I said, I'm shocked. We have 3 BDRs discussed in 3 meetings. That's unheard of. But anyway, that's excellent. Having said that, I think we can move to our next agenda item. You want to take on Joseph from here?
Yes, and this is Joseph Philippi for the record. And again, I'm just going to reiterate what Dr. Khan said. I'm truly appreciative of you all. I think that in such a short time that we've been meeting since May, coming up with 3 meaningful BDR topics and actually getting them drafted and submitted by our deadline is pretty phenomenal. So thank you all for that.
Thank you very much. You have been the driving force in keeping us all posted, informed, and I think you and I have talked more than I have with any executive director in my previous boards and commissions. So thank you very much. Keep up the good work. So we can now move on to our next subject.
Thanks, Dr. Khan. Joseph Philippi for the record. So don't know how much time we all want to spend on this today. I know that just getting those BDRs done was a lot, but the next agenda item is for possible action to discuss the governor's executive order and propose next steps. So thinking forward over the next few months, I kind of came up with this proposed meeting plan. We have been meeting monthly up till now. So this plan would propose continuing to meet monthly at least until November or December, to continue to review different recommendations that we've received related to addressing the workforce challenges of the state. And then ultimately, I was thinking by October, having you all conduct a work session of some sort to review and approve a final list of workforce recommendations that you are supportive of and wish to have included in your final report submitted in by January 1st of this next year. So, because as you all know, the executive order requests that within your semi-annual report, the next report is due January 1st, that you include recommendations on how the state should address various areas of the healthcare workforce challenges. So proposed next steps would be after today's meeting again in September, having potentially some additional presentations on various workforce topics. And then we still have a solicitation of recommendations. That list continues to grow. It's kind of slowed down recently, but we are still having recommendations come through from various stakeholders in the public on how to address the workforce challenges that we face. So really diving deep into those recommendations, asking questions and if needing any clarification on any topics, happy to do that between meetings and get as much information for you as possible so that we have a robust discussion. But then ultimately coming together in October to review a final list. Once we have a final list of recommendations that you all are supportive of, we can then, as your staff, work to draft a report including those recommendations and supplemental information to then have you all review and approve your final report. Ideally, potentially we could have that report ready by November ahead of the holiday season so that we're not trying to meet too much during the holidays. But if we had to meet in December for some reason, I'm sure we could schedule that. So that's my proposed next steps. And then ultimately a discussion that we can have later on is how we want to move forward within the new year. As you all know, the legislative session starts at the beginning of February. I'm not sure if we want to reduce the number of meetings that we've been holding, from monthly to every other month, or if we want to start meeting quarterly, similar to other boards and commissions. But truly think that we can continue to look at workforce, but perhaps develop a subcommittee that just focuses on workforce so that the commission as a whole can look at other areas that are under your scope, related to healthcare access, quality, and affordability. So this was just a proposed plan. Doesn't mean we have to follow it to a T, but just wanted to start that conversation and see if there's any feedback from you all today.
Joseph, a couple of questions. One, how soon would we get back the final draft language vetted by Legislative Counsel Bureau and the AG's office, so that what's our deadline again for information for all of us for the BDR? Is it first?
So for the BDR, we have to submit the draft language by September 1st, and then I've been told that it takes approximately a month or so for LCB drafters to review that and actually get us an official draft back. So I'm thinking we would receive an LCB draft sometime in October for you all to review. But then there is a hard deadline by November 20th of this year for any bill to be basically pre-filed. So what that means is once we get the LCB draft back and you all review it and it looks good, we just have to basically confirm with them that we wish to now pre-file this BDR for the next session, and that has to occur before November 20th. Any BDR that isn't pre-filed by that date won't move forward and won't be introduced in the next session. So I would think that if we get it submitted by the 1st of September, if not sooner, that we would receive hopefully those initial drafts back from LCB sometime in October.
Thank you. So as far as we are concerned, we are done with our proposed BDRs. Now it's their job to tweak it and whatever else. So we would have met the deadline of 1st of September, since as of today, we finalized our subjects for the BDRs, correct?
That is correct, Dr. Khan.
Okay, so then, so our part is done, which is great. And then we'll just wait for the other side to do their job and get it back to us in October, whenever they're ready. And our next meeting is going to be somewhere in October, I believe, or September.
September. Yep, I was thinking September, just to have another meeting to have maybe a couple more presentations on workforce on certain topics, and then ultimately coming together in October to review a list of workforce recommendations that have either been received from you all as commissioners, or that we've received from various stakeholders, and really diving deep into those to draft and develop a final list that you wish to include in your final report.
So great. So the question I would have also is, we are meeting somewhere in the end of September. We can only hope and pray that the LCB has gone through our paperwork and done their draft language so that we can wrap it up at that next meeting. If not, then we'll have to do that in our October meeting. Right now, I would like to hear from our commissioners, any other suggestions, thoughts regarding the meetings or the timeline?
This is Walter Davis for the record. I think we have a momentum going here, and I don't want to lose that. And so I think that we need to continue on as planned.
Okay, great. So that sounds like a plan. Joseph, anything else you have to add?
No, Dr. Khan. Joseph Philippi for the record. I just appreciate again all your time and all the work that you've done and so far. So like what Mr. Davis just said, I hope we can just continue the momentum and really have a great report at the end of this year that makes a difference. So.
And so that takes us, if no other comments from the commissioners, we can go to our next agenda item, public comment. Do we have anybody for public comment, Joseph?
Anyone wishing to provide public comment, please press *5 if you're joining by phone, or raise your hand through the Teams platform. Dr. Khan, I'm not seeing any hands raised.
Okay, so I think Once again, credit to the commission. This is the shortest meeting of this commission in the last 3 years, literally. So kudos to you all. Fantastic. Then I'll call for adjournment. Have a motion to adjourn? Yes,
I'll
no?
move to adjourn. This is Bethany.
All right,
I'll
second.
second.
All right, nobody is opposed, yes. All right. So it carries.
Thank you all.
Thanks a million.
Thanks, you guys.
All right, thank you. Bye-bye.
Thank you.
Have a great
Bye.
weekend.
Bye-bye.
Happy Friday.
You too.